Afternoon and welcome to our NHS West Yorkshire Integrated Care Board. We're here in Leeds today for our board meeting for November this year, and we have a number of things on the agenda. And for those watching online and have come to observe the meeting here in the room today, we have a number of people around the table who are board members representing the breadth and depth of West Yorkshire's Health and Care Partnership, including representation from different sectors and our 5 places. Today on the agenda, we're looking at primary care, specifically general practice, and that will be complemented by an engagement session that we had earlier today, particularly with people working in general practice, GPs themselves, as well as practice managers, and working with our colleagues from Health Watch. Our agenda today also includes looking at winter planning, as well as our performance in terms of finance, quality and safety across the system. As you know, every one of these meetings, I think this is our 8th full meeting in public, aims to cover the 4 purposes of an integrated care system. So that's around improving outcomes in population health and healthcare in West Yorkshire. It's also around tackling inequalities, particularly in the experience, outcome and access to services. And as a board, we're very interested in variation in services and delivery, and also enhancing productivity and value for money. As you know, that you've got a report on our system finances for 23-24, and also the 4th purpose of an integrated care system around our broader social and economic development, which links with our integrated care partnership, our partnership board, which will be meeting in Halifax on the 5th of December. So I'm going to quickly go around the table because we have some people deputising for colleagues today, as well as some people who haven't been to our board meeting. And it's also helpful for people who've come to observe the meeting or are watching online. So I'm going to ask Harris, if you would start us off and we'll go around the table that way. Would you introduce yourself, Harris? Thank you.
Hello, I'm Harris Sultan. I'm on the next direct placement, which is a non-executive development placement on NHS West Yorkshire.
Good afternoon, everyone. My name is Fatima Khan Shah and I'm the West Yorkshire Inclusivity Champion.
Hi, I'm Tom Reid and I'm the Chief Executive of Leeds City Council. I'm a sector representative of local government.
Hi, I'm Mel Pickup. I'm place-based lead for Bradford District and Craven and Chief Executive of Bradford Teaching Hospitals.
Hi, I'm Jane Madeley. I'm a non-executive member and chair of the Audit Risk Committee.
Hi everyone, my name is James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board.
Hi, I'm Becky Malby. Nice to meet you, everybody. I'm a non-executive member for Future Generations.
Hello, I'm Anthony Keeley. I'm from NHS England. I'm the Locality Director for West Yorkshire.
Afternoon, everyone. I'm Nanshu Chatterjee, non-exec member and chair for Finance, Investment, Performance and Transformation Committee.
Hello, everyone. I'm Kate Sims. I'm the Director of People for the ICB. Thank you.
Hi, I'm Jonathan Webb. I'm Director of Finance at the NHS West Yorkshire Integrated Care Board.
Hello, my name's Rob Webster. I'm the Chief Executive.
Thank you, Rob. I've introduced myself earlier, but I am Cathy Elliott. I am Chair of NHS West Yorkshire. Over to you, Laura.
Hello, I'm Laura Ellis. I'm the ICB's Director of Corporate Affairs.
Hi, I'm Stacey Fleming. I'm Governance Manager at the ICB.
Hi everyone, I'm Majid Hussain, one of the non-exec members. I look after, focus on people and equalities. Thank you.
Hello, I'm Carol McKenna. I'm Place Lead for Kirklees.
Hello, I'm Robin Tuddenham. I'm Place-Based Lead for Calderdale and I'm the Chief Executive of Calderdale Council.
Afternoon, everybody. I'm Kim Shuttler. I'm the Sector Lead for the VCSE.
Good afternoon, I'm Brendan Brown. I'm the Chief Executive at Calderdale and Huddersfield Foundation Trust and the Sector Lead for the West Yorkshire Association of Acute Trusts.
Hello, I'm Sarah Munro, Chief Exec Lead in York Partnership Trust and Sector Lead for Mental Health and Disability and Autism Services.
Good afternoon, my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Hi everyone, I'm Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees and Sector Representative for the Directors of Public Health across West Yorkshire.
Good Good afternoon, I'm Heather Thrippleton, Associate Director for Health Watch across West Yorkshire, and I'm deputising for Hannah Davies today.
Hello, I'm Richard Vautry, I'm a GP and I'm the primary care member of the board.
Afternoon everybody, I'm Jo Webster and I'm here representing Wakefield District.
Good afternoon everybody, I'm Catherine Giles, I'm Associate Director for Primary Care in West Yorkshire and I'm here to support the Primary Care Focus agenda item.
Thank you, everybody. And Catherine, thank you for joining us today. Our colleague Ian Holmes is unable to join us today, so I know you're helping to deputise for him as well. So thank you. For anyone who's watching online, live or on record on our website, we also have observers here today, and we have representatives of the public, NHS England, and representatives from general practice as well. And thank you for joining us. So I'm just going to get us through some of the key usual business, I suppose. So we've done our introductions. Laura, could you just note the apologies for us, please?
Yes, thank you. We've got apologies from Ian Holmes, from Hannah Davis, and Heather is deputising as she advised. We also have a number of board members who are leaving at various points. So Richard Vautry is going to be leaving at 2 o'clock. Tom Reardon and Heather Thrippleton are going to be leaving at 4 o'clock, and Kate Sims will be leaving at 3 o'clock and returning to the private board meeting. Thank you.
Right, thank you, and we'll record that in our minutes as well. If you're watching online, you may not also be able to see that we have colleagues from our communications team who also work on our involvement framework and practice across the whole of West Yorkshire. And Karen, would you just introduce yourself? I know you're over in the corner, but just so colleagues around the table know who you are. Thank you, Karen, and thank you to you and your colleagues for joining us today. We continue to work as NHS West Yorkshire to make sure the work of the board is profiled, and that includes social media activity that we'll be doing this afternoon. So can I just check, are there any declarations of interest today, board colleagues, in relation to today's agenda? It's in being open, transparent as a board. Becky.
Hi, Becky Malby. I'm the author of the Universal Healthcare Report and have been doing work on that across the country. So it's part of the background papers for the primary care.
Thank you, Becky, and that's in relation to item 6. Does anyone else have a declaration of interest? No? Okay. Thank you for that. That's in relation to today's agenda. There's also then gives me the opportunity to remind you all to keep your declarations of interest up to date in our new online portal as well, which Laura and colleagues in our governance team keep an eye on. And that also helps us with our compliance with fit and proper persons as well. Thank you. So next we have on our agenda item 3, which are the minutes of our last meeting. If you remember, we met in September in Bradford together. We had a focus on session on mental health, and Sarah and Therese and Keir came to talk to us particularly about ways in which we can work on improving and removing barriers on mental health, as well as best practice that's taking place across our system. Colleagues, first of all, can I check that that's an accurate record of the minutes that day when we met in Bradford? Yeah, I can see nods around the table, which is great. Thank you very much. Should we then go on to the action log? Laura, will you highlight what we need to be aware of?
Thank you. Yes, if you're looking at your packets, page 20 of the pack for the start of the action log, I'll skip to the open action. So the first open action is item 5, which relates to some amended wording to need to go into the May board meeting. I will pick that up outside of this with Harris, who had some suggested wording. So I think if we could move down to open action 9, which was from the last meeting, and it was for Jonathan in terms of the capital funding. Am I okay to pass to Jonathan? Yep.
Okay, thanks, Laura. So this was around ensuring that mental health and capital and learning disability capital needs were sort of picked up within the wider work across West Yorkshire. Just to confirm that since we last met, we have now commissioned NHS Property Services to work with us to develop a West Yorkshire-wide infrastructure strategy, which will cover off all of our sectoral needs in terms of capital. The initial thinking is that that report is due to complete by the end of March, so we'll just schedule in an appropriate discussion within the Finance, Investment and Performance Committee either in February or in April, and we'll agree that with the chair of the committee.
And just say thank you, Jonathan. I think that's really helpful. Capital priorities within West Yorkshire in the NHS obviously have been a watching brief for us since autumn last year as we became a statutory body, and we've had discussions both in public, meetings in public and meetings in private as well. So I'd really welcome us keeping an eye on that and reporting going forward. Rob?
So yeah, I just think it's worth reminding everybody that this is really in relation to the fact that for large capital schemes, there's a national approach and funding that's available, and we've been beneficiaries of some of those large programmes. For local capital schemes, we have a sum of capital that we deploy, but there's a group of schemes which might be 70, 80, 90 million, which we would have to collectively agree to fund over a period of years from our allocation. We can only do that, I think, if we've got a proper capital strategy and prioritisation. That's why it's really important. At the same time, I think we need to continue to reflect back that there isn't a natural home for that size of development in the arrangements that exist at the moment. So that's why we collectively keep working on it.
Thank you for that clarification. Laura, then the rest of the action log.
Thank you. Yes, the two remaining open actions, number 10 and number 11, whilst they relate to different things, were both actions for place leads to take back into place committees following last time's meeting. So I don't know if any place leads want to provide an update on those. Thanks.
Great. And that's, as colleagues know, every time we have a board meeting in public so far, we've had a focus on session on a certain service and aspect of health and care, and it's a request for place committees to have a look at that as well. So colleagues around the table, perhaps if you've got an update now, please let us know, or we can weave that into future AAA reporting as well, which would be really, really welcomed. Okay. Tim.
Yeah, just in reference to taking it back, it's on the agenda of our committee for December, so we have put that on the agenda. I think it's probably also, we tend to use the sort of catch-all of place committees. I suspect most of us have governance structures and conversations that are much broader than those committees. So certainly we've picked up, we had a long partnership executive group looking at our mental health community changes maybe a month ago. So there's more than just the committee. Subcommittees.
That's really helpful. Thank you, Tim. Okay. And we'd welcome hearing from other colleagues through the reporting and the rest of the meeting as well. Thank you. Becky.
Just in the really important work that we did last time around mental health, we amongst the actions, most of which I think are going back to the collaborative, but there was one about how we were going to advocate upwards around funding for autism and ADHD. It'd be really helpful to hear if we've made any progress with that, please.
Thank you. So, Sarah, invite you as our system lead on mental health, learning disabilities and autism.
Yeah, so firstly, there is no new commitment of any funding, and we're not anticipating any in the announcements that we've made tomorrow. However, explicitly, the national team in NHS England for mental health have been asked to work up a set of proposals specifically in relation to autism for children and adults. That's at the request of Maria Caulfield, the Minister for Mental Health. So that work has just started. We're also, through the national group, doing a similar exercise around ADHD and the ability to produce the same set of asks and recommendations with the aim of those starting to feature more prominently when we look at the long-term plan for mental health. So those conversations are happening. Obviously, it's being able to navigate and ensure they land in the right place so that we get a response that would be something that we know our citizens would want to hear.
Thank you, Sarah. And colleagues know around the table, at every meeting there is something that comes through that we may want to go and have a discussion and influence colleagues within our region or national partnerships that we have, including NHS England. So there's an example, and I'm sure we'll have examples later on when we talk about primary care. James, do you want to come in?
Yeah, I suppose it's just in addition, just to, I suppose, reinforce and say that I take, and I know others do, take every opportunity when we are discussing whether it's regionally or nationally in terms of kind of pushing that point in terms of I suppose, supporting what Sarah is having in terms of the discussions there to make sure that it's kept on everyone's agenda where it's appropriate there. So it's just really just to reiterate that and make sure people are aware that that is happening.
Great. Thank you, James. That's really helpful. And as health and care leaders around the table, we all play a role, don't we, in influencing as well as working within our system as well as with others. Rob?
Yeah, I just wanted to make a general point that I think this is a system, and the Department of Health and Social Care, NHS England, CQC ourselves, the partners around the table are all part of the same system. So these are system conversations, often described as lobbying, but I don't think it's lobbying. I think it's genuinely, if we think about everything as a system, everyone has a role to play in it. We've got a legitimate role in saying these things are issues that need addressing within the construct that you've created. And I think that's the way we approach it, very positively and very constructively. I think Sarah's reflected some of that in the work between the Minister, the Department and the collaboratives.
Okay, thank you. I'm going to move us on now. We'll move on now. Are there any matters arising, from the minutes? Is there anything on the that's missing from the action log? Becky, you followed up there on that point on influencing nationally. Looking around the table. No. Okay. Thank you. So now we're going to move on to item 4, which was the urgent decision. Laura, do you want to just please give us an overview of that?
Yes, thank you. So this is a notification of an urgent decision that had to be taken before today's board meeting. It is here for ratifying by the board. It relates to a number of terms of reference for some of our committees, so the Finance, Investment and Performance Committee, Quality Committee, Transformation Committee and Remuneration and Nomination Committee. We needed to make some fairly minor changes, but they were significant enough to mean that we needed to do them under the urgent decision process. The detail is all set out within the report, so I won't go into the individual specific changes.
Okay, thank you. And also these changes link with the appendix in my report as chair in item 7 in some finessing of board remits and roles, having tested our ways of working and the workload over the last 15 months or so as well. Colleagues, are we happy collectively to ratify that together in terms of the changes? I can see nods around the table. Great, thank you. So that was the urgent decision. We have that formally ratified. So now we're going to move on to item 5, which are public questions. And we've had one question submitted by Dr. John Puntis, who's here today as well. Thank you for giving your time and sharing the question with us in advance. I'm going to hand over as usual. We ask Laura to read that out, and then we ask a colleague representing that service area in that part of health and care to respond. And then we will provide a written response afterwards and put it onto our website. So Laura.
Thank you. So I'll just read out the question we've received. So I'd like to ask a question related to agenda item 6, a focus on primary care concerning physician associates. I note the acknowledgement that there must be a clear explanation to the public about how general practice is operating and what they can expect. There have been concerns recently about patients mistaking physician associates for doctors and the potential clinical risk involved. Whereas physician associates can undoubtedly be valued members of a team, they require supervision by a doctor, and it is unfair to ask them to act outside their competency. Some of the Royal Colleges and the BMA are exercised about the role of physician associates currently. You may remember the Panorama programme on practices in London where physician associates were acting unsupervised and in fact being substituted for GPs. I see that in the Yorkshire ICS, it is anticipated there will be 26,000 more staff from the additional roles reimbursement scheme, which includes PAs, and at the same time there has been a decrease in full-time equivalent GPs. The National Long-Term Workforce Plan anticipates an increase in the number of physician associates. I would like to know how many physician associates are currently in post in our ICS region and in which clinical specialties, how many additional physician associates are anticipated by 2024, and whether the board has any views both on defining appropriate job descriptions in terms of roles undertaken by physician associates and the necessary levels of supervision required in order to ensure patient safety. And I'm going to pass to Catherine Giles, who's going to provide an answer. Thank you.
Thank you. Firstly, I'd just like to point out that with regards to physician associates, it's very similar to, it's the same as all other roles in general practice, that it is the employer's responsibility to ensure that there's the right and appropriate level of support and supervision in place. In West Yorkshire, we have supported the physician associate role through working collaboratively with the West Yorkshire Training Hub, and we've put in place a preceptorship 2-year programme. And that's available to general practice and also PCNs. The preceptorship programme, it was created to establish the PA role in general practice and make sure it's safe and sustainable in primary care. There is more information available on the Training Hub website as well. That really does help support and demonstrate that the model that we are supporting in West Yorkshire is in accordance with the National Clinical Quality and Governance arrangements. So the programme that's in place started in 2020 and it started initially with a cohort of 7 PAs. We have actually had additional cohorts since in March 21, January 23, and it's accommodated 15 PAs in each cohort, and we're looking to do another cohort as well. The programme does include teaching and support, so it covers a range of common clinical conditions in primary care, such as diabetes, CVD and women's health. And all preceptees do have a practice-based assigned GP mentor that works with them through their portfolio. And there's also peer support sessions available that are facilitated by a GP, and they are care-based discussions. So the actual numbers that we've got of PAs currently in West Yorkshire is 59 all-time equivalents, and we are forecasting, I think, around 65 in the next year as well.
Thank you, Catherine, for that response. And John, thank you again for that question. Your interest in our continuing work. We'll publish that on our website and make sure that Dr. Puntis has his own response as well. Just to say to anyone who's in the room today, as well as anyone watching this meeting, you're always welcome to contact us as NHS West Yorkshire. There's further information on our website in relation to public inquiries, opportunity to submit freedom of information requests or seek assistance in terms of complaints or PAL service. Our next board meeting will be on the 16th of January, and questions from members of the public are invited by the morning of the 15th of January, and we'll be publishing information a week in advance of that board meeting, so you can see what we'll be talking about that day. So thank you. We don't have any more questions, and so we'll now move on to our focus on item. So as you know, but if you haven't been to a board meeting for a while, or this is your first one, we have a focus on item. It enables us as a board to have some time together to work to fully understand, as best we can in the time that we have, what's going on for a service across the health and care sector. We understand the great opportunities and the great work going on, and also understand what the challenges are and the barriers, and are there barriers that we can enable our colleagues to remove? Is there something that we need to do as NHS West Yorkshire? Or the discussion that we had earlier, is there something we need to do in terms of influencing regional and national colleagues? So today we are looking at primary care. We're looking particularly at general practice. And for those of you who were with us in November last year, that was about, this report is about a 1 year on review. So that's what the report particularly looks at, what we discussed a year ago and where we are now. It also reflects on responding to NHS England's NHSE's primary care recovery plan, as well as what we want to aim to do together in West Yorkshire. And before I hand over to colleagues Catherine and Carol and James and Becky to talk further about this, and Richard, particularly I wanted to share the engagement session we had earlier today, hosted by Healthwatch and West Yorkshire Voice, sitting with GP colleagues and practice managers, where we had this very open discussion about things that were positive and working well, and the good feedback that we're receiving across West Yorkshire, as also the challenges, but hopefully solutions that we can find together as well. So thank you to everyone who contributed to that session. Some people have had to leave, but we really appreciate that, and we'll have a write-up of that session on our website as usual. So Carol and Catherine, would you start us off on this discussion? We'll then invite some other colleagues to contribute, including Becky, James and Richard, and then we'll get into a broader board discussion. So Carol, to you. Thank you.
Thank you. So, afternoon, everyone. I'm presenting this on behalf of Ian this afternoon, who unfortunately isn't available. So, thanks to Ian and Catherine and other colleagues in West Yorkshire, and also within our places, who've worked together to produce this report on a collaborative basis. And it does aim to reflect the fact that we do much of our work on primary care in our places, but equally where it makes sense to come together and do so, then we do work together as part of that sort of virtual team, as it were. So, as the chair has already said, this report serves a couple of purposes. It's intended to update everyone as to the work that's happened since we had the conversation in Huddersfield last November. And at that point, we were talking about the fuller stock take and what that meant for us locally, but also recognised that it reflected very much the direction of travel that we were already on in West Yorkshire. Since then, we have had the publication of the Primary Care Access Recovery Plan, referred to as PCARP in this report, and probably for speed in the conversation that follows. That was published in May of this year, and that set out some quite specific requirements of us as an ICB and in our places in relation to access to general practice in particular. However, those two things are not separate to each other. They're very much part of our integrated approach, that if we're going to have continue to improve access to general practice, we're looking at creative solutions, working with partners in our localities and in our neighbourhoods. So it's not a case of, neighbourhood working over there and access to general practice over there. They are part and parcel of the same thing. So just briefly then, within this report there are 8 recommendations, and I'm sure we will touch on all of them and obviously come back to them at the end, but just to sort of highlight and try and draw them together, those recommendations are broadly drawn from a few areas that have been highlighted in the report. So firstly, as I've already said, there is some updates on the work we've been doing around integration in our neighbourhoods, and we heard more about that this morning in the listening session as well, and it was great to hear from colleagues some really good examples and some really targeted examples as to how care was being improved and delivered to some of our most vulnerable populations. So we heard some really good examples of that already today. There's also some very specific information in the report on performance metrics, which we now report in a way that I would say wasn't necessarily the case a couple of years ago. We do have more information on access to general practice than was previously the case. I think you can always debate as to whether or not that's the sort of information that we want, or whether it's telling us about what's important to us or not. But it doesn't change the fact that we've got a lot more robust performance information than we had before. And what you will see from looking at that is that there's a lot of positives there about the increased number of face-to-face appointments, for example, being offered by practices, and also a level of variance as well that you would expect to see. And actually, part of the conversation I was involved in this morning, we talked quite a lot about variation and recognised that in some cases you don't want variation because it can't be justified, but equally in others variation is absolutely appropriate, and it's important just to recognise that nuance. The report also references the Universal Healthcare National Inquiry report, and we have had discussions within our local Fuller board as to how we may be able to utilise the work of that report in our local work. And then some very specific examples, some very specific requirements in response to the Primary Care Access Recovery Plan. There are things that we are required as an ICB, as a system, to consider in a formal setting, which is what we're doing today. And to also sign off and endorse. So you will see a lot of that assurance work has already happened within our individual places so far. And there's a whole range of examples of specific things that are being done to improve access. And then there's some particular ask of the board in relation to the work that we've been doing around the primary-secondary care interface, which does feature in the PCARP and has been subject to, I think, of discussion in this board previously when we've talked about the connection between different parts of our system and how what happens in primary care affects how the work that happens in secondary care and vice versa, and being able to manage that connection in a way that doesn't sort of pass on responsibility where that could be avoided and make things better for everyone is something that we've spent quite a bit of time considering. There was a workshop held in West Yorkshire led by James in October, and it involved medical directors, I think it was from all of our acute trusts actually, as well as primary care clinical leads from all of our places. And from that workshop there is a recommendation that this board endorse the Royal College of General Practice joint standards. And I think that's really important and will send a really strong message to us in our places as we take this work forward. And then just finally, and picking up from the conversation this morning, there are some specific references to the further strengthening of clinical engagement as it relates to primary care, and there's some examples in the report of new things that are now in place that weren't all in place when we spoke this time last year. So there's some positive developments there that we hope will serve us well as we continue to move forward. So I think I will stop talking there. Cathy, thank you. I'm sure other colleagues will have lots to say.
Oh, Carol, thank you very much for that really comprehensive overview. I think it's incredibly helpful. And this is something we're trying to do, weave in what we're hearing from colleagues across the system, guidance and requirements nationally, as well as continuing with our plans aligned to the Joint Forward Plan and the strategic plan. Catherine, can I invite you to give some overview? And then I think if we come to James, Richard and Becky, and then I'll open it up to discussion. Catherine.
Thank you. Not a lot more to share in terms of what Carol's already said, but I think it's helpful to just, again, reflect in terms of what's in the board paper, particularly around performance and how well we have done as a system. And the board paper reflects the operational plan commitments, and we are doing really well in progressing all of those three areas around the appointments and around the introduction of the additional roles reimbursements and the other appointments trajectories in the paper. I think, you know, we have to just be mindful of the fact as well that whilst we're doing well in some of the areas and we're doing exceptionally well in delivering the access recovery plan targets, there are still some areas of focus that we need to think about, particularly with regards to enabling patients to see their records through the NHS app. So we know that we've got some work to do in terms of accelerating that particularly, and there's some really good work that we want to now to start to accelerate through the Pharmacy First, which has just been again published nationally. So that will really try and help accelerate the integration between general practice and community pharmacy as well. So that is highlighted as part of the recovery plan. So there's some really big pieces of work that we do really need to focus on between now and the end of March. But overall, we are doing really well in progressing some of those key requirements nationally and also locally with regards to what we have indicated within our joint forward plan as well.
Thank you, Catherine. James and Richard, as GPs around the table, but also the board roles that you have, I'd welcome hearing from you, and then we'll come over to Becky, James, and then over to Richard.
Okay, thank you, Chair, and thank you for another opportunity to kind of highlight what's going on across primary care, not only through this paper, but through the engagement session this morning and hearing the kind of feedback across primary care. And it's good to see the positive elements that we're seeing in the sharing of good practice. Catherine's just mentioned about in terms of where we are in terms of performance, and that's great. And it's important to understand in terms of the productivity across primary care and what it's delivering, both in terms of appointments, in terms of access, despite the challenges that we hear. I think there's lots of great learning we're hearing in pockets across our places, and that's where it should be happening. It should be happening in our places and in our communities, and that needs to be the continual focus, which I think it is there. So it is a great opportunity to be able to kind of highlight what's happening across primary care there. It is about, Carol mentioned about collaboration, it's about integrations, collaboration across our communities, with the different with our communities, with those individuals, with our population there. It's collaboration, integration also with the stakeholders and other members across those communities there. Carol's highlighted the workshop that took place in order to bring together not just primary and secondary care, although there was a dominance of that there, but actually it's much wider than that. And whilst the paper, the access plan specifically talks about primary secondary care, I think as a system, whilst we recognise that, we also recognise it's much wider than just primary secondary care there. So Karen, who's sitting behind me in terms of communities and services, and the collaborative was there. Our mental health collaborative was also present there. There are other people there as well from the different sectors, because it's about developing culture and relationships, and I think that's one of the big things that came out of those discussions there. There's a real willingness, recognising the impact that we have across primary care and secondary care and our community and mental health services of different actions we take, but actually working together collaboratively there. We're not ending up passing the buck, adding the workload and impacting on the possibility of delivering services, often to actually some of the most vulnerable people as a result there. So I think and also I think in terms of bringing us together as a system, recognising at a system level there's a certain amount we can do, and it's really important that our leadership are highlighting these issues, but it's about what happens in our places and our communities there, and again that was recognised there. So I'm I suppose from a board point of view assured that that is happening, assured that from a clinical professional leadership in our places across our different sectors, there's a real real emphasis on developing that culture and relationships, which will then enable us to kind of look at how we're working collaboratively and in an integrated way that not only benefits our patients, but also actually benefits the people who are working in these areas there, because as we know, the pressure and the impacts that is having on our workforce, and actually to be able to deliver those services, we need a happy, healthy workforce, and part of that is about building those relationships there. So I think there's a lot of positive from the papers, a lot of positive that sits behind that paper there. But there's also, I think it's important, from a board point of view, we also recognise those challenges there, because yes, there are lots of good bits of work that's happening there. I think and I heard this morning at the engagement session there, it's about really understanding and having those honest conversations with our public about what is within our gift within primary care and there. But also, it's about, I suppose, there's something about prioritisation. It's about having those honest conversations there, because there are challenges there. But it's also enabling those challenges to kind of develop what we are aiming for, which is kind of joined up, integrated care across primary care, across our sectors, that is delivering what our public want and need, and to meet their care needs there, and also to kind of support the workforce so that we can really encourage people coming into the workforce within primary care from lots of different kind of elements of our community there, because it needs to be developed within our communities. I think I'll stop there, but I can go on.
Yeah, no, I know. Thank you, James. Could you just, for the board's information, particularly for anyone, because we have people around the table who don't work in the NHS, for example, you've talked here about endorsing the adoption of the joint standards in the Royal College of GPs guidance. Could you, in lay terms, maybe, and just very briefly, what does that mean? So that colleagues around the table were being asked to support that today. And then Richard will come to you.
Can you come back to
you'll
me
have
on
a
second?
view.
Right.
Yeah, the Royal College guy.
Probably I'll just get them up so I can give you a complete awareness of that, but I'll put it into layman's terms in a second there.
Richard, just welcome hearing from you, and also again on that standards in the Royal College. I know that you have a very prominent role with them.
Yeah, well, I should declare an interest that I'm the president of the Royal College of GPs, and I have been since Saturday. I just wanted to pick up on one or 2 points, if I may. Firstly, I just want to put on record my thanks, and I hope the board's thanks, to all of those who work in general practice. It has been an incredibly hard year for everyone working in general practice and wider primary care. Since we last met, we've probably had the toughest winter that many can remember in their lifetime of working. We've faced rises in flu cases, rises in strep A, and the anxiety related to those issues as well as the ongoing workload issues relating to day-to-day general practice and the pushback from the long waiting times in secondary care. All of that having a real impact on the ability of patients to get appointments, the ability of practices to provide sufficient capacity to meet patients' needs. But nevertheless, I know my colleagues across the region have done their level best to maintain as good a possible service as they could. And I think we should recognise that and give them thanks for that. There's just 4 points I just wanted to pick out in terms of what I think we as a board and as a system need to do going forward. And they are highlighted in the report, and I'm grateful for the authors of the report. One is about the retention of GPs particularly. I know this is a national priority of Claire Fuller, the newly appointed Medical Director at NHS England, and I think it should be our priority as well. We're doing better at recruiting GPs, often from many countries around the world. We have large numbers of international medical graduates joining general practice, which is a good thing. We need to support them and help them, but we also need to retain the workforce that we have. So that is about managing their workload, appreciating them, enabling best use of their skills, and a variety of other initiatives that we need to do. And it links in part to the public question that we had earlier about how we focus on expanding that GP workforce, because that's one of the best ways that we can ensure our patients get good primary care services. Secondly, and it's just been alluded to by yourselves, is about the primary secondary care interface. I draw board members' attention to paragraphs 5.3 and 5.4 in the paper where it says primary secondary care interface is one of the most important elements of the recovery plan. Again, it's nationally identified, it's been picked up locally. I'm grateful for James and colleagues for leading that discussion, but it certainly needs to continue and really motor much more focus. This is everybody's problem. It isn't just a GP issue, it isn't just a secondary care issue, it's largely a patient issue because we need to ensure that patients get the service from whichever clinician they meet in the system at that point and aren't shuffled around to somewhere else in the system to do that work on their behalf. And we need to find systems, improve systems and create systems that enable that to happen in an effective way. And the document you referred to was has been published by the Royal College of GPs, and it refers to some of those very practical things. And it really boils down to doing things once rather than passing it on to other people to do it, so that we enable those things to happen wherever possible. The third thing is estates. We have many practices in our region who want to do more, who would like to do more, have recruited more staff to do more, but are limited by their estates. And I know this is a national issue, and I think we need to, as a system, try and identify what are the inhibitors locally that we can ask and work, as Rob alluded to at the beginning of our meeting, within the system to overcome this issue. Because if we want a happy, well-being workforce, we need to ensure that the estates enable that. And we've been really fortunate to recruit some really highly skilled staff supporting general practice, working in general practice. We need to retain them, and one way of retaining them is to improve our estates and the space that we offer for our patients. And the final point I'd like to make is about empowering patients. And again, it's much more work about stopping over-medicalising issues and stopping driving people and encouraging people to just go to general practice, when in many ways, many of our citizens can do things themselves if we gave them the tools to do it themselves. It might be about access to their records. It might be about stopping saying, maybe from a school or from a council office saying, go to your GP for this letter or that report, when in many cases, patients can be given confidence to do it themselves and provide that information to themselves rather than over-medicalising things and disempowering patients. So I think we can do much more around that, and that would help everyone, I think.
Richard, thank you very much. That's really appreciated. Thank you. James, can we just come back to you and just do anything you want to add in terms of that Royal College guidance? Then we'll come to you, Becky, and then I've got a list of people, Tom, Fatima, Kim, and if anyone else wants to say something, please let me know. Harris as well. James.
Yeah, no, so apologies for that. But so it feeds on to what Richard mentioned there in terms of the primary secondary care recommendations from the RCGP is very much around making sure that kind of clinicians and teams are kind of when they investigate things, they follow up those results, so we're not passing that on onto other teams to do there. It's looking at making sure when patients are being investigated that they're informed at the time, so they're not having to go back to see their GP in order to be able to tell them why they're doing that there. It's also making sure commissioners are ensuring that kind of providers have waiting well initiatives in place so that keep people informed, so that this is where we're seeing patients ringing up GPs to find out where they are on the waiting list and what's happening when in fact they haven't got that information at hand in order to be able to tell the patient there. And then when patients are being put on new medications or being new therapies, that they're being informed at the time or at a reasonable time of what that means, what that involves, again, rather than suggesting to go back to the GP in order to be able to kind of be updated of what that means there. So it's kind of making sure that those people who are initiating the therapies are actually giving the information to the patients, keeping them informed and not expecting them to then go to the GP who may not have that information all the time. So it's those areas there.
Thank you very much, and we can send a reminder around afterwards as well for colleagues. Thank you. So we have got about half an hour or so to hear from as many of you around the table as you wish to want to contribute. We're going to start with Becky. I'd really welcome, we've got Becky, Tom, Fatima, Kim, Rachel, Harris, Majid, AC. I'd also want to invite our place leads to share their contributions. So Joe, you're starting us off there. I feel like I'm starting to run an auction now. Robin, and also Brendan, you've got a long time to wait, but whether we can just have a view from our acute collaborative as well in terms of that point. Yeah, no, I'm building you up there on that secondary interface as well as Sarah from you. So I'm going to try and get as many of us in the next half an hour. Please can you speak as close to the microphone as possible so everyone in the room as well as you being filmed on to go online can hear you. And we'll now begin with Becky and then we'll hear from Rob you at the end in terms of a conclusion. Thank you. Becky.
So thank you. It's a complicated and complex world that is being oversimplified. So what we know is that where people have good care from their general practitioner, that does not correlate with the number of appointments that general practitioner offers, because it's about meeting needs in the quality of the appointment, not volumes of appointments. So we can have practices that are offering a lot of appointments where patient satisfaction is very low, and we can have practices offering a fewer appointments where patient satisfaction is high. So my concern, first one, is that we need to do some pushback about the metrics, about what we measure and what we pay attention to. If we offer more and more appointments, the people who can access those appointments, people who speak English, people from certain wealthier classes who are already getting more appointments are going to get more, and those people who have less ability to get those appointments are going to get less. So it's going to drive up inequalities. So that points to us about developing a new model, and that's where I think this paper is beginning to get to us for. So we know that people that turn up frequently, a good percentage, around 10% in some practices, are people who are poor. That no amount of general practice can solve the fact they have a damp home, they have poor finances, and we have to work on how do we help those people in a different way. At the moment, general practice is sweeping up every single problem in our society, and the demand has increased with productivity increasing by about 20%, but it's not the best use of our expert clinicians, James and Richard, to help people with their housing problems. So we have got to manage the appointment system so that we can collaborate more with our communities, our voluntary and community sectors, our faith communities, to help people in poverty. And I think we have to make that visible. How much of NHS demand has been increased because we do not have enough money going into people's pockets where they need it to feed their families and to heat their homes. The NHS can't stick in plaster that. So that's the first thing. Second thing is that if we're going to think about how we access general practice, then we have to think about different models, which is not that everybody has to come into general practice. We saw some fantastic examples in West Yorkshire. We talked about them this morning, where our GPs are going out into communities where they are to meet their needs collectively, where they are, because accessing their general practice is so difficult, and doing that in a way that helps them transition back into the NHS. So that isn't more front door general practice. That's a different way of thinking about general practice, that it's not about sets of appointments, it's about meeting needs. So the design of general practice has to change, and this report needs to generate that. I think that means Joe, I'm sure will want to come in on this. I think that means we have to think about how we fund and support the metrics around general practice and the money around the development. So when we've thought about hospitals, Brendan, you've had a really significant investment in hospitals around quality improvement. General practice just hasn't had that. It hasn't had the sort of wraparound development arm that the hospitals have had. It hasn't had an academy, a primary care quality thing. And you'll see from the report that only 6% of our practices are accessing the national offer. That means it's either that, for me, that probably means it's inaccessible, or it's inappropriate, or it's too difficult because of the time constraints. It doesn't mean those folks don't need support. They do. So I think we've got to think much more imaginatively about how collectively across West Yorkshire we spread the really great things we've got going on and we help those practices that are struggling. So those practices that are struggling, you can absolutely pinpoint them because they're ones where patient satisfaction is low. But we could name and blame them, or we could properly support them and say, why is it? Now, we know that our poorer communities are offering less appointments, have less ability to secure general practitioners and other staff. And we also know that their funding is less. So we have to start thinking differentially about where is it the patient satisfaction is low, because that's probably where we're struggling with quality. And they go into those places or support places to go into those practices and give them the support they need to be able to offer the same as every other place. So if you look in the report, you'll see that people who have gone IMD5 is a poverty decile, so those are wealthier people, are all getting more appointments. always than people on IMD 1 and definitely on IMD 2 to 4 across the patch. Now that's for me is that, that we're here to be fair for everybody, so we need to do something about that. So if we're going to be thinking about the support to our general practices and the way we measure, then I think we've got to think about how we invest our differential funding to support those practices struggling so everybody gets a fair offer. And I think we have to think about the spread of innovation. So absolutely lastly, if we're going to think about the medicalisation of poverty, the spread of good practice, a new model of care that reaches out to people, then we need to give practices some space around that. But Richard, I'm not sure it's more GPs. So I think what people often want is continuity, and I think general practice satisfaction is improved if you offer more continuity. So I think we have to get on the proactive foot. And the way we're doing that is not going to be, as this paper says, to cut bureaucracy, which I fundamentally disagree with. General practice, in terms of its management costs, operates at under 1%. Hospitals operate at 4 to 5%. Most corporates in this country operate at 9 to 10%. We are so undermanaged in primary care. That means there isn't the business intelligence, there isn't the admin functions that enable general practitioners to do what they should do. So I don't believe in cutting bureaucracy, whatever that is. I do think we need to be investing properly in enabling our general practitioners to understand need and to mobilise their really expert clinical work around the clinical work they should be doing, and enabling others to pick up the rest where possible. So we have got to think about that whole notion of particularly around business intelligence. We've struggled with our R's roles trying to get some digitally enabled business intelligence into PCNs. And lastly, if we're going to have additional roles, and it was really good to hear about physicians associates as a question, thank you so much. If we're going to have additional roles, it should be based on need, not assumption about need. And the lack of data in general practice means we really don't know what that need is. So if you're going to invest in more additional roles, then you have to really understand what sorts of folks are turning up where. And we know that we can often have an assumption that people who turn up frequently are people who are frail and elderly with complex needs. That is not the case. In the majority of the situation, you'll find at least 50% of people who turn up frequently have either got poverty issues or mental health issues or other issues that need to be dealt with across the system and owned by the system, not just landed in primary care for it to sweep up. So I think we have to collectively own those and work out a model that works for those people so they get looked after where and by who they should be.
Thank you very much. Thank you, Becky. And I know that you've been supporting exec colleagues behind the scenes as well in sharing research and data as well. So thank you. And I don't expect you all to be in a violent agreement with each other today either. We've got to find a way forward, though, for the sector and our colleagues in health and care. So I'm going to invite people in groups of threes, and then I think Carol, Catherine, Richard and James, if there are any points of reflection you want to make as we go through those groupings, just please let me know. Otherwise, I'm just going to go through the list that we have here and then come to Rob at the end on a reflection. So we have Tom, Fatima and then Kim. So Tom, to you.
Thank you. Yeah, I think the report's quite helpful in the sense of correlating between our local plan and how we have clearly prioritised this agenda, and because it's self-evident from the sort of geography and the socio-economics of West Yorkshire that we need a neighbourhood-based approach and an integrated approach to to tackle the wider issues that we know are the determinants of the challenges that we get in the health system and the care system. And the National Inquiry Report seems to completely align really with what we've been saying and what we've been intending to do. I think the challenge for us is that the system gears us against this approach in the way that's been described, and so you've almost got to push against the tide to make it happen on the ground. And there's some great early examples of that, but it is, I think, about redoubling around the areas that we focused on in November 22, a year ago, and on workforce, I think there is more we can do in terms of the thinking about the wider workforce that we know are the key to this, which does bring in council staff, it does bring in voluntary and community sector staff, it brings in healthcare assistants, etc., and the community health aspect particularly. And we were having a discussion with Tim today about how things have changed for the council services in the last decade or so, and the calls to our helplines and the conversations we have, just as GPs are dealing with housing issues and financial issues of patients, our teams are dealing with health issues as well. And so they've, and then the calls are taking longer, and the people are just desperate for help, and there's more of them who are in crisis. So somehow, I think we've got to improve the understanding between the different workforces. Secondly, I think we do need to double down on the referrals element of this and try and make sure that we link in not just data, as we discussed last year, but I think technology solutions to try and help. But the other thing that's happening obviously on the ground is this massive financial challenge for not just within the health service, but particularly within local government, where we're all taking decisions in the next few months that are going to be probably having to restrict and reduce services, to reduce our estate in the areas that we're trying most to get to these communities. So with that, I think we've got to turn that into some sort of opportunity with colleagues in the primary care system to think about how we can provide services in a different way, have more integration between what we do. We've got good examples of that, but it is incredibly difficult once you've got an agreement that you're going to house NHS services and council services in the same building to actually follow through on. I mean, I think it took us 18 months to get this agreement about having the same reception, and I cannot tell you how that should not be rocket science, but it is in our current system and the way that we work. So we've got to cut through that and get a much more a place that people can walk to in their communities, where they know they can get referred and access to the right people, whether that's health, housing, finance, or wider mental health issues. And that goal has got to stay the same, but we've just got to get practical about how we can do that with what's happening probably with the council estate at the moment, and make the best of that and turn that into opportunity.
Thank you very much, Tom. And again, I'm sure you could talk for much longer on why it took 18 months, but I think we've got these number of examples where barriers need to be removed. And I take your point, Becky, on bureaucracy, and some of that is coming from a national plan, but there's a point there in trying to remove a barrier, which we can come back to in a moment. Okay, we're going to go to Fatima, Kim, then Rachel.
So every time I hear Richard and Becky talk, I want to applaud, because they just they put the fire in the belly, don't they? I mean, Tom's absolutely right in what he's saying, which is part of the challenge is people are only going to the door that's open, and they want help and they want to get it from wherever they can access it. And sadly, sometimes the GP's door is the door that's open, and actually what's manifesting in that consultation room is not a health-related issue. It's actually something more complicated than that and requires a solution that might be something beyond the consultation room, which is why our commitment to personalisation was so important and continues to remain to be really important. I was privileged enough to lead the People and Communities workstream of the Fuller Stocktake, and it enabled me to speak to a number of different stakeholders on this agenda. And one of the things that really resonated with me was just how tired general practice was, and just how much they felt vilified by the narrative that they're not working as hard as they can, and this narrative of them and us. And I really think that if we want to change the future of primary care, then we need to support a way of working that enables people to lead the solutions, working as equal partners. And I'm not sure that I've seen that as strong enough in this paper as we potentially could. And we've got some really good structures, but I think we could strengthen it a little bit more. We also need to think really creatively, and there was a lot of discussion actually, Richard, about estates, believe it or not, in the Fuller Stocktake, but also about no shut door on every door leading to support. And we talked proactively about utilising other venues within communities for people to be signposted to. The issue you will have, though, sadly, is that our voluntary community sector is really struggling too. And many of them are sadly unable to operate because of the cost of living crisis. So if we're trying to develop solutions with our public, we need to be really honest about what isn't within our gift. And as Tom's alluded to, things will get significantly harder because the support that people want sadly may not be available. So we need to bring people with us in a way that personalises the solutions in a way that is meaningful and not one size that sadly doesn't fit all. The other area that I think is really important for us to remember are those people that are at the door. So our receptionists in general practice are absolutely instrumental, and we need to think about, when we're developing capability and supporting our workforce, how we support them. And also reflecting on some of the lessons I learned as a primary care commissioning committee chair about the elements of deprivation and the challenges of recruiting people, that one size isn't as easy to recruit to as others. So recruiting somebody in Dewsbury is not as easy as it may be in Leeds. So how do we make that more attractive and also enable people to remain within those GP practices and more connected to their communities too? Because actually that's what GP practices and leaders were telling us was really important to them to enable this to succeed. The final thing that I think, and you alluded to it a bit, Tom, was the use of artificial intelligence. So this is gaining lots and lots of traction in health circles and leadership. And one of the biggest areas that I hear as inclusivity champion that people have when it comes to accessing care is the use of translation and the fact that the service provision could be better. And are we really exploring for a society that is used to receiving goods and services in a timely fashion at a time that they want it, when they want it? Are we exploring all the digital options that enable us to do that? And I wonder whether we could explore that a little bit more.
Thank you very much. And that came out in our engagement session as well, if English isn't your first language, about looking at interpretation services and improvement of that, but also thinking differently as well. And we had an example of a service going out to where a refugee community was meeting and improving cultural competence in general. So that was some themes from earlier today. Okay, we've got about 15, 20 minutes left, and we've got lots of people who still want to speak, and I'm really pleased you want to contribute on this. So we're going to go to Kim, linking well on the voluntary sector piece, Rachel Harris-Majid. So Kim, to you.
Thanks, Cathy. I wasn't going to speak specifically about the voluntary sector today, but thank you to my colleagues who I think said a lot of what I wanted to say. I suppose my comments are about challenging us as a board to think about what is our role in making this happen, because I think it's really important for us to get the assurances in line with the recovery plan that we're expected to give, the numbers and all of that. But, and I can't remember, it might have been one of Brendan's phrases, or Rob's perhaps, how do we avoid the ticking the box and missing the point on some of this stuff? It's yours, yeah. And like Becky said, focus on the outcomes for people and have that sharp lens on health inequalities that we all sit around the table for. And I suppose my question that I was thinking is, we have a lot of people around this table who have within their gift to make things happen. And are we really articulating a vision for radical change which stops the sticking plasters, which we might be driven to do, and is really ambitious for our people and communities and our colleagues in primary care, recognising that we, this is very much the words of some of my primary care colleagues, can't just keep doing more of the same. So I don't think really, even though there is the fuller report, that we have spent a decent amount of time thinking through what is our collective vision for radical change in this space, and then be really clear about what is in our gift to make that happen, what are the enablers, and how are we going to measure the progress on that? Because we need some of that radical change now. I think, if we just focus on the tiny little pockets of best practice, which of course there are, it's going to be too slow. And we see our colleagues falling over every day under the pressure. So I think it was the challenge to the board, and probably one for us to think about outside this meeting.
Thank you, Kim, and something for our fuller delivery board to take on. Thank you. We're going to go Rachel Harris-Majid next.
Thank you so much. Just to say, it's always really, really nice to hear about the conversation around inequality and public health. And I think one day I'm probably not going to be needed on this group because everyone does this job for me. But I guess just on data, I do think, as Becky said, it's extremely important that we get good data to be able to understand what we're trying to achieve and how we can improve things. But I think sometimes it's easy to forget unmet need in that, which no amount of data at a local practice or PCN level will give you. And that's how we marry up the population level intelligence we have across our places to genuinely understand what that unmet need is likely to be. I also just wanted to mention the sort of the dilemma and between people wanting to know their GP and a need for anonymity in certain cases. So in certain communities, we do have people who want anonymity and would want to go and seek advice that perhaps they don't feel like is shared amongst their community. And it's really that balance, as Fatima said, of people that represent communities, but people that also are trusted in terms of making sure that they can provide advice and people can raise any issue that they experience. I do think that GPs and all practice staff have a real responsibility around every contact counts, and they do that so well. And I think that's really important with things like vaccinations, because actually we do know that if somebody refuses, particularly childhood immunisations, and then their child gets ill, just a normal bug, it's a real opportunity that that behaviour can change in terms of revisiting that decision, and maybe we can get the uptake of some of those childhood vaccines up across the borough. I just finally want to talk about kind of poverty, and I know a number of colleagues have mentioned this, and I think that there is a real opportunity, I think, across West Yorkshire to use some of the tools like poverty proofing. We did a presentation at Calderdale and Huddersfield last week about how we could poverty proof some clinical pathways within the hospital. And I know we can't do that for everything within general practice, but maybe that sort of poverty proofing might actually help us understand what are those issues that, as colleagues have mentioned, are presented with, and how can we look at minimising some of that through general practice, and then clearly use that, as Tom said, to link into some of those broader services. And social prescribing, and obviously the huge amount of work the voluntary community sector, we need to understand that capacity and also fund it properly, because otherwise we're just creating a problem elsewhere. I think very finally, and again, this might be a little bit picky on my part, but I thought the report was helpful, but it did assume you'd read everything that came to last year's report. And actually, I was thinking about a member of the public who came to this as a new item. It would be helpful, I think, for a summary of what is the vision for primary care and the outcomes, just so that anyone can dip in when we've got a focus on discussion at the board.
Thank you, Rachel. We can rectify that on our website and also refer to any NHS guidance, including the fuller stock take that we could put there as well. So that's making sure colleagues and members of the public are informed. Okay, we have Harris, Majid, then AC, then Joe. Harris.
So I have 3 points, one on climate change, one on public awareness, and one on children and young people's mental health. So I acknowledge initially on the cover paper of the paper it says it's not applicable, the impact of it on climate change, but I think there's a compelling argument that embracing a digital landscape in primary care has the potential impact significantly reduce the carbon footprint, as evidenced by various research and studies in other healthcare systems. So how can we effectively convey this environmental impact, particularly in the context of rolling out digital improvements? And considering that there is a notable reduction in CO2 emissions due to decreased travel time, appointments, or even decreased time of practitioners going to meetings, like the way Skyscanner highlights reduced carbon footprints for flights, how can we use this information in patient advocacy and awareness? Because if you tell patients the positive environmental impact of embracing these online conditions, we educate and engage them into the broader understanding of the healthcare system, healthcare landscape. My second point on a culture shift. I was at a community centre in Wakefield, and there was someone with type 1 diabetes going on saying they never actually see a doctor anymore, they always see a nurse. And I think there needs to be more work done getting the public to understand that there's such a diverse range of healthcare professionals available for appointments and that they don't need to see a GP. And my final point on children and young people's mental health. We have such a great way of using young individuals in service design in the mental health area. In Bradford District Care, you've got Young Dynamos, in Leeds Community Healthcare Trust, you've got the Youth Board. But if you look at primary care involvement groups, they're predominantly the older end of the population. So how do we leverage this learning from the mental health trusts of how we involve young people? And Richard, I'm really glad you mentioned schools. And I know we went on about the over-medicalisation to prioritising mental wellbeing and education in our last board meeting. But how can we use the primary care sector to facilitate this shift? And Tom, you mentioned a one-stop shop. This is what young people want in healthcare. So how can we incorporate general practice colleagues for a radical redesign, as well as harnessing things like the Health Innovation Network to work with primary care to have a transformative change for children and young people's healthcare?
Thank you, Harris. That's really helpful and complements what's been said, but brings it from a very fresh perspective, and I appreciate that. There's been a continuing theme around particularly highlighting the diverse range of professionals, which if some of you came to our engagement session last year, people were talking very openly about how they found, to their surprise, some different kinds of professionals who were incredibly helpful to them in their health and well-being. Thank you, Harris. So we're going to go Majid, AC, Joe, Robin, Brendan, Karen, Rob. And we're going to try and finish up in about 15 minutes. So, Majid.
Thank you. Thanks, Chair. A couple of points. It really builds on Becky's point about helping people in a different way and Richard's point about not over-medicalising issues. So if you look at the police at the moment, they're looking at this concept of right care in right place, and they've screened every single one of their calls, every single incident that they've been to, and said, well, this is a policing issue, this is probably a voluntary sector issue, this is a mental health issue, etc., etc. But they've not said, okay, we're going to stop doing this now. What they've done is, right, okay, who can address these issues? And they've sort of done a landscape map of the place and said, right, who's best to place this, deal with these issues, engage with them and sort of come up with a plan on how to do that. And I think there's a lot of learning for us from that space and that work. So I think first point is what can we learn from elsewhere? Second point is Tom and others have mentioned that they're looking at their own budgets, etc., and looking at reducing costs, and there's efficiency challenges across the public sector. But wherever we hear these conversations, there's always an assumption there's an infinite capacity within the voluntary sector and they're going to save us. So I think my second point is really, really important that public sector collectively need to have a look at what are they doing, where are the efficiency opportunities, and how can they collectively work with the voluntary sector to support, develop and pick up some of these issues, because that's the right place to pick them up, but they need resourcing. So I think it shouldn't be done independently, where every public sector organisation in their own mind is relying on the voluntary sector. So those bit of learning and a bit of joint working.
Thank you, Majid, and thank you for our non-execs around the table, Majid, and we'll come over to UAC again from another non-exec perspective.
Thanks, Kathy. So I had a bit of narrative before the three questions that I was supposed to ask, but I think the narrative has been covered between what Becky said and Tom highlighted, and Richard picked up on 5.3. So I'll start with 5.3 there, and I think specifically the second part of that sentence, in which I think it's fairly important and in future papers, looking at working and streamlining the patient journey with the benefit. So to understand the patient journey in places should be fundamental from this perspective when we're looking at primary care transformation. So a bit more narrative and focus on that would be useful, because that's only the single point where it was mentioned about patient journey. RCGP framework. I think there was a reference to Waiting Well initiative. So my first question is, for the 2,400 patients that are waiting in our current set of system, do we have these in place, and how are we managing that? The second question links to 6.3, and again, that's a fundamentally very important observation to what Harris was sort of referring to, a lot of how questions, which refers to mapping of models of engagement in place and system level. And it sort of alludes and acknowledges that there is a varied level of understanding how we operate across the system and places. So the question is, when is that mapping exercise going to be delivered? So it says that we are planning to do that and identifying to address any gaps. This is particularly important going back to the RCGP framework again, when we are thinking of reducing inappropriate administrative work, also local, looking at sort of optimizing local formulary. So when we went to the mean good practice, I think, visit, we saw one example where we could have done with that in terms of discussion with the local sort of place-based teams on standardizing that approach, which the RCGP frameworks recommends that we do. So it will be useful to do that mapping exercise, which sort of brings out what those gaps that we need to close. And the final point being is, again, thinking about creating an action plan based for each places, because we are going with the principle of subsidiarity. So where can we get the clarity in terms of the fuller board looking at those plans, which is then abstracted to, somebody mentioned about the primary care vision, in terms of it will be useful to always correlate these discussions or contextualize the discussions around that plan, and then contextualize against an action plan for the places over a period of 3 years, which then helps us, because we can't transform everything at the same time. So if we help prioritize X amount of initiatives over a period of 3 to 5 years for each places, then we can focus on those particular activities and, more importantly, create a meaningful medium-term financial plan. Because we have to create room within the financial budgets to be able to do those transformation, because else there is no additional money that's going to come from anywhere else, as far as I understand.
Okay. Thank you, AC. The specific question about the people on waiting lists and are they waiting well, I think if we get time in this section, we'll answer that. If not, we will come back to that when we look at the integrated performance report. Okay, thank you for that, and I've noted those down. We're now going to hear for some place perspectives. So Jo in being our place lead for Wakefield, and then we'll hear from Robin, our place lead for Calderdale. So Jo.
Thank you, Kathy. I don't disagree with what anybody has said, and really when you get to this point in the discussion, many points that I was going to say have already been said, but I just want to sort of just emphasise some of the things that I think have been successful in Wakefield, which of all the points that everybody's made. And before I do that, my first job in the NHS was a practice manager. And I feel incredibly privileged to still be working with general practice in the way that I am. It was a fantastic induction into the NHS and social care, and because you get a range of issues that come through the front door, and it was a real great opportunity. So I feel really privileged to work in Wakefield with some fantastic GPs and other professionals. We've improved all the targets. Our appointments are going up, our face-to-face contacts are going up. We're recovering all the backlogs that we had from COVID and when we had to pause or interrupt any of those arrangements. But one of the things that I think we're doing is that we're doing that in a very different way in Wakefield, in that we're giving authority for general practice to develop mutual accountability with each other and supporting each other to do things very creatively and innovatively. So we're reaching out to communities, which I know many of my colleagues are doing exactly the same things, because we learnt that worked in COVID. When we were doing COVID vaccinations, we were reaching out into communities where they were harder to reach to, rather than those coming to us, which obviously talks to what Becky has suggested. And we're also integrating with other health professionals. So the benefit that I have in Wakefield is that we have created conditions for integration to thrive in a very different way. And so we are linking with Social Care Direct, we are linking with social care practitioners in a way, we are linking in and working alongside our voluntary and community sector. We're working with our reablement teams in a very different way to stop them going into hospitals. So there's a range of opportunities that I think have been brought about by the way in which we're integrating care. And we're also linking data together. So we're not just looking at data from a single sector, we're linking that. So we're looking at pathways and we're looking how people access those pathways. So it gives us greater insight into how people's journeys through the system work. And one of the things that I've always been quite ambitious about is, whilst we haven't got any more money, which we all need more money to do things, we have a whole lot of resource available to us that we just need to redesign differently to get the best out of that. And one of the things that I've been quite passionate about is whether or not we could use the power that we have as a West Yorkshire system and the collaboration that we could have to have our own quality outcomes framework. I'm looking at Richard. Wakefield wouldn't be able to do that on its own, but there are a number of things that are currently, I think, we could call it bureaucracy, we could call it non-added value, parts of the way in which general practice works that they get paid by, that we could change the way that that would work, that would give us greater outcomes. But we do that in a way which is outcome focused and not prescriptive, because I think it's as much about how we work with general practice that I found the success of Wakefield as much as what we do. So I hope that makes sense, but I suppose what I'm saying is, why can't we have a West Yorkshire quality outcomes framework that's targeted on less prescriptive way of working, more outcomes focused, so that we can then devolve it into our communities.
Thank you, Jo. And that was echoes with the conversations that we had this morning about less transaction and more quality. Thank you. Robin, a view over from Calderdale. Then we're going to go to Brendan and Karen with sector views, and then we're going to finish up with Rob and then make some decisions and have a break. So, Robin, over to you from Calderdale.
Perhaps a similar tone to Jo, really. I again, not disagreeing with what's been said, but I think coming into NHS from local government, it's shocking, I think, how we underplay how amazing primary care is and its influence in place and communities. And we do need to do things better. And on data, I do absolutely agree about the don't cut the bureaucracy thing, all that nonsense. We do need better data. We are doing work with our 5 PCNs around digital transformation, dedicated transformation leads. There is real variation in practice. So overall, we've seen a slight reduction in satisfaction across the borough. 5, though, practices have actually significantly increased, 4 significantly decreased. So, and we're looking at an improvement programme, working with those places, parts of the borough and those practices where we need to improve, and some of that is around access and digitisation. So I think there is an issue about data, and data needs to be loved and nurtured. But I also think we need to love our primary care teams and our practitioners as well. I mean, to talk about the love and care they bring to places, and convene these amazing people, these amazing teams. So we've done part of this we've done through the local authority, we've done a scrutiny deep dive, scrutiny a day on general practice. We've had a small group of counsellors working with a team of GPs and primary care practitioners for the last 12 months. We've got a 7-point action plan that does connect nicely into this. It's got a very big focus on comms and engagement. We've got something called It's a GP Practice Thing, which is about GPs being out there, linking to some of the wider work that the NHS is doing as well. Last week, they were out there talking about World Diabetes Day, making films. Our primary care staff represent our place and our communities, probably more than most other parts of, I think, the public sector, and it's really striking, and they are rooted in their communities. The other thing that we've done is have a primary care strategy group with a chair and vice chair appointed through the LMC. They sit on our partnership board. They've had a really powerful conversation in the couple of last weeks ago on community pharmacy and the untapped potential of the links there. So actually convening and setting the strategic framework as practitioners is important. And the final thing is, I don't think we should underestimate, we talk about sometimes community-powered NHS, and some practice at its best is that now. So we've got primary care practitioners doing active lives work as part of the Active Calderdale pilot with Sport England. We've got them working with faith leaders, monitoring community tensions. Actually now, they're part of our community tension management frameworks in really, really difficult times, growing food around practices, part of edible landscapes. And finally, a GP sent me some photos, very proudly, over the weekend, out with St Augustine's with a group of asylum seekers doing clean-ups, linked into the local surgery. So I do think there is something about nurturing, loving and valuing primary care and recognising we need to improve it, modernise it, but actually they are neighbourhood workers, ambassadors at their best, I think. Thank you.
Robin, thank you so much, and it connects so well with the neighbourhood model, but you've talked so much more eloquently in that way, so thank you, that's really helpful. Brendan, we invite you to give a perspective from the acute sector, and then Karen from the community sector, and then we'll start concluding.
Okay, so I think the days of Dr. Turner on Call the Midwife are long gone, clearly. But I would just ask this board to be more curious about how sectors are working. I think we've slipped into old language about or assuming that there are those who have or those who have not. And I think there are GPs in this room and public health consultants who've worked with acute trust chief execs here who would say, arguably they are just as interested in the education and the work and the housing and the long-term living conditions of our communities. And I would hope that we would be more curious about how we're working collectively in what we are doing, and that there is a conversation that checks out about sectors sharing their resource. We've talked about having or have not, but actually I could talk endlessly about the data science sharing that we've adopted in Calderdale and Kirklees to do what we've been describing. I think we need to pay attention to the future, those who are currently working for us as we've described, but also the future workforce in primary care. But probably to Joe's point, we need a different conversation about what does primary and secondary care really mean? What does it mean to the public? What is the primary element of this versus the secondary? Every sector in this, around this table is seeing an increase in demand with a workforce that is struggling. That's the conversation I think we should be having, notwithstanding the attention that needs to be paid to the primary care elements. So I don't want to labour the point, but I think there's a different curiosity needed in this conversation. With the language we've used about frequent flyers or frequent attendees, our communities are attending frequently for a reason. We need to pay attention to that.
Thank you. I think that's really helpful. And again, it's how we would like to take this forward as West Yorkshire, as well as respecting national guidance that's coming through. So thank you, Brendan. It's a continuing message about working in an integrated way, in partnership, in neighbourhoods, which is really helpful. Thank you. Karen, to you, seamlessly from a community perspective. And then we'll come to Rob. And
he's put it on a plate, hasn't he? So, yeah, I'm Karen. I represent community services in this room. And I suppose where I'd come from is we have a vast array of colleagues who support people to thrive where they live. And we need to think really differently about how we use them all. And that covers the voluntary sector through community services into our doctors in general practice, but also our pharmacy colleagues, our optometrists, all those kind of people. And indeed our acute sector, who we need to reach out if we're going to support people with more complex needs in the place they live. We are going to need the support from our acute sector to help us do that. So that outreach into that space is going to be absolutely critical. We have a lot of people who are working in people's homes and actually can probably upstream quite a lot of this. And if we think, playing to Becky's point here, think about how people live and how we need to support them, I think that brings a difference rather than applying a standard model to how we think they should live. Frankly, it needs to be about how they live. And we know that from my sector, if we work with our practices and with our PCNs, we actually bring some real difference in the room. So playing to Robin's point there, as a social enterprise, we've supported setting up gardens, so growing things where people live, pilots around gynaecology services for particular sectors of the community who aren't accessing those kind of services that we've supported. So we know that if we understand the places we're in, we can do it differently. And I'll just give you one example of something we've done recently. We've worked really hard with MAST PCN recently, where we got all the people who work in that place together, the frontline people, and we did a bit of sharing about what do you all do and what do we all do. And actually that learning was really critical. What we learnt about pharmacy and what we learnt about patients and what we learnt about what the district nurse does actually brought some real difference into the room about one, and how are we going to fix this differently then? So that thing about place, but everybody involved in the place to shift the dialogue and to use the resource collectively, for me, was really important. Thank you.
Karen, thank you very much. So we have now run out of time on this discussion. No, Karen, you do not apologise. I think that was a really helpful way to end. Our colleague Ian isn't here to reflect. There's definitely a whole host of information here that we can then give to our fuller delivery boards. Our place leads are here to take that on board. There is messages around redesign, respecting place subsidiarity, working with a neighbour model. There was a message earlier in our engagement session about systematic neighbourhood working street by street, making every contact count, and also a challenge on radical change as well. But there is something about working together here and no competition in them and us, which is very much what we've moved away from for a long time. Rob, I wonder if I can invite you to, I suppose, sum up, and then I need you all to approve and support some recommendations in the report as well.
Yeah, so thank you everybody for the conversation and for the paper and for the work that's gone on every day. I think it's probably worth starting by saying that this time last year we'd probably just seen a step change in public satisfaction and confidence in general practice, which was double digits and was not welcome, I think, for anybody. And what we've seen in this paper is that we've stabilised the position and improved it, which is good. We should note that first, and that's been because of the hard work, effort and energy of all those practices, and as Robin said, the wonderful people who work in our communities across all of the sectors. So that's the first thing I think we should clock. I think the second is that that's necessary but not sufficient, and as Becky's pointed out in the universal healthcare work suggests, there's a different way of approaching this, which we're probably going to have to adopt. And in doing that, we're going to have to recognise it's all of our roles, not just general practice's role, to sort this out. So it was really pleasing to hear Harris talk about children. We know that children's services in community in healthcare generally commissioned by councils. We've heard about the pressure that councils are under. We know that integrated joined up services for children are fundamental. Just yesterday I was at the Baby Week in Bradford, talking to some of the integrated teams that work in children's services in Bradford, and they were fantastic. Talking about how you get food, vitamins, other support to families who are struggling with children under 4, for example, from the Acute Hospital Trust. So there is a piece of work that we all have to do here. And when I look at the recommendations, I think we have to go back to the thing that Brendan didn't say. No, he did say, I think, the stuff around ticking the box, missing the point. We do have to stop admiring the problem and start doing something about it. And the action plan, I think, starts to do that. But there's some things we talked about today which I think should strengthen that further. So when we look at the further action that can be taken at system level support and enable local service transformation, I think we've all identified there isn't a change model and capacity that we're putting in place for this sector collectively, or not a strong enough one. So we should consider that. The estate strategy that Jonathan talked about earlier, and Tom talked about the issues in our places and through councils, can we make sure that picks up primary and community services in a very direct way? The CDIO role that we're about to recruit to, looking at the digital strategy, can we make sure that implements the digital requirements of joined up services? Can we make sure it also looks at population health management and data, the bureaucracy, if you like, of general practice and micro-commissioning that needs to be much stronger? So I think those things need to be in the action plan at this level, directly supported by the board, and we need the assurance that the estate strategy does do that, the digital strategy does do that. I think the universal healthcare report, I think we need places to take that away, to look at their integrated team offers in each place, and what we're hearing around the table are some brilliant examples of where that is the case, but we need to do much more, and Joe's put on the table a solution to that we might want to think about collectively around outcomes. So again, the fuller board should probably consider that. In terms of the next year, I think it was AC who talked about the medium-term financial plan. This work is fundamental to the medium-term financial plan because we're talking about what we invest in our communities to keep people well and flourishing and to address health inequalities. We probably need some options in the medium-term financial plan that says what's your balance of resource and investment. Yep. So previously we'd said we wanted a differential investment. So what is it this time? And again, we should ask Jonathan to come forward with the finance group with some recommendations around that, which builds upon the fuller board's requirements. And then my final reflection, we haven't really talked about, I've touched on it, but I think it needs to be much stronger. I think the clinical engagement piece is necessary. Again, I don't think it's sufficient. We need clinical leadership. And we've got 52 clinical directors of primary care networks. Who's a group of people we should be mobilising alongside us to try and drive this agenda with their partners. So I'd want to see that strengthening a bit, I think, Cathy. But thanks everyone for the conversation. And to echo Richard's point at the beginning, the board should, I think, thank general practices for the work that they do every day.
Thank you. Thank you very much for summing up. I think there was a point earlier, Richard, you made right at the start about the retention of GPs as well, and that reiterates the thanks to the breadth and depth of people working in primary care, and working also to retain them in their roles and in their communities as well. So we've had a breadth of a discussion. There's a number of us making notes to make sure that these things are then carried into other discussions, and we'll do a summary of that. The specific recommendations that we're asked to support today. So there's a number of things about discussing, noting, supporting. But one thing we're asking the board to do is endorse the adoption of the joint standards and the Royal College of GPs guidance, which Richard and James as GPs around the table shared earlier. As a board, are we supportive of that? Yeah, and we can do some follow-up information. We also are being asked to endorse embedding findings from universal healthcare, and Rob outlined ways in which we can then ask both the full delivery board and places to look into that and use that as a tool. Do you all support that as well? Yeah, that's great. And I don't really need to ask this, but support developing and implementing new models of primary care for our communities based on a neighbourhood model. And I think there's some challenges here about redesign, if not radical change. And if I remind you all as a board, our risk appetite goes up to bold, and it feels like this is a moment where we need to be very seriously considering that. Okay. Colleagues, there's so much more there. We will revisit this. I was just checking in with Laura. I wonder if we ask Carol, Catherine, James, Richard with Ian and Becky and others to come back to us perhaps at the March meeting as sort of your progress. Perhaps not as a fuller, that's not a pun in any way, not a full board report, but I think a progress report would be really welcomed, and then hearing from colleagues as place leads around the table about what you're progressing and you're proud of, as well as what you're improving upon. So we've slightly overrun, but it feels an incredibly important topic for us, and we know our colleagues at Health Watch and members of the public tell us this is an important service to them, and we need to get it right for people in West Yorkshire. So thank you for that discussion. We're going to pause the meeting now. We'll take a 5-minute break, come back at 2:20, and that means we'll pause the live stream for anyone watching online at this moment as well. Thank you.